I switched it then. Hello, Web Shadowers. Welcome to our summer week 6. This is our last session for summer, and we would like to thank you all for joining us tonight. Tonight, we have the pleasure of hosting Dr. Ramzan, who will be teaching us all about family medicine.
As always, please remember that the Google form will be posted in the chat and in the description of this video when the session is over. So with that being said, Dr. Ramzan, you may start whenever you are ready.
Okay, thank you guys so much for having me. I had so much fun chatting with you guys out in the fall, so I'm so happy to be back. I'm going to try to keep this really informal. I put in a couple of cases, so I hope it's informative. This is the same introduction I had last time, so for anyone who didn't see that last one, I'm a family doctor. I work in Toronto, Canada. I did my undergraduate degree in biochemistry, then I went and did my medical school, both from the same university, the University of Ottawa, which is the capital of Canada. And then I came to Toronto to do my residency in family medicine, and I've been working on my own as a family doctor for 7 years. And I work in a community clinic in a low socioeconomic area. So I think a lot of my experience kind of reflects along that. And I also work as a medical director of a non-surgical cosmetic clinic. I don't really talk very much about that, but you guys are more than welcome to ask me anything that you want in terms of that as well too. So last time I came and spoke to you guys, I introduced Mr. Sunshine, and apparently it was well liked. So I thought I would continue with this same person. So Mr. Sunshine's a 50-year-old male who comes to your practice, who's part of your practice. And, you know, I'm basing this on like what I would actually see in terms of during COVID. So at the moment, I'm mostly doing phone calls, but I will see people in person if required. So this Mr. Sunshine comes and he basically tells you he has chest pain. So the question is, what would you want to know about his chest pain? And so the talk today that I'm going to sort of focus on is basically chest pain in an outpatient setting. I thought it's kind of an interesting topic because a lot of times we talk about chest pain in the emergency room, and there's sort of like a different kind of differential or different possibility of what that could be. And I feel like it's a little bit different thinking about it from a family medicine perspective when you're actually like in the clinic. So I'm gonna topic because a lot of times we talk about chest. Oh, sorry. I'm just trying to see if I can see. I wanted to try to make it interactive, so I'm keeping an eye on the YouTube live. So if you guys are able to interact with me, that would be awesome. So that way, this will be a little bit more fun. I mean, I can give you the answers to this, but obviously, the whole point is to see if you guys have any ideas about what would we do next, kind of thing. So. Any ideas on what to do? What would you want to ask him? What would be like, in terms of a starting point, like what kind of things cause chest pain? So I guess we have I'll give you guys a couple of seconds because I know sometimes it's a little bit delayed on the live. Yeah, so ask him about a history of heart disease, ask about when the pain started. Someone's saying like CHF, which is congestive heart failure, the type of pain. Yep, heart disease. Yep, whether the food, if the pain is from food that he had, does he have shortness of breath? Like MI, so heart attack, what makes the pain worse or better? Stress, family history. Yeah, listen to the heart. Yeah, you guys these are really good. Where the pain is. Yep. What point of the day does it get worse? Heartburn. Yep. I think an exertion. That's a really good one as well. So what I did was created a list, and this is not an exhaustive list, but I just thought sort of for me, I actually kind of still use this division in my mind, and I think it kind of even helps patients because everyone thinks that chest pain is mostly related to the heart, and that's everyone. Your patients will call me like, "Oh, I think it's my heart." So, heart attack, angina is basically there's just not a good enough blood flow to the heart, which then can lead to someone having a heart attack. And then you can have different types of injuries to the heart. The point of my talk is actually not really to go into all the nitty-gritty details, but sort of like an approach and like how, blood, this is kind of like a real life example of what I see. You can have issues with your lungs. So any type of infection, pneumothorax is when the lung collapses. A pulmonary embolism is when you have a blood clot in the lung. Again, so a lot of these things, are probably things you would see in the emergency department as well. Do I see some of these things as often? Not really. I tried to give some cases where I talk about like some of the weird and wacky stuff and then sort of more the very common stuff. People forget that, your chest wall, actually, you have ribs, and in between your ribs, you have muscles. So people often forget costochondritis is inflammation of the muscles in between the ribs. We also often forget to talk about, like injuries or that kind of stuff. I have patients who've had accidents and, where they had the seatbelt, they actually have ongoing chest pain. So it's more muscular. And then there's, in the same area, you obviously still have like your stomach. So people always think that because you have stomach pain, like stomach pain is sort of different than chest pain, but though it is, your stomach is a little bit behind the chest and people can have reflux, as people kind of talked about heartburn. Peptic ulcer disease is basically having an ulcer in the stomach. H. pylori is a bacteria that can cause an ulcer in the stomach. And then some other stuff like anxiety and panic attacks, which I think are less commonly thought of, but also actually quite important because there's a good chunk of my patients who end up in the hospital and they end up having anxiety as their cause. So someone's asking about if I use Oldcart's method of pain. It's a good question. Prescribing chest X-ray or CT scan. Yeah. So, and someone talked about EKG. So you guys all had really good commentary here. So you know what, I think you can, there are different acronyms obviously to use. I was taught OPQRST, but I mean, you can use other ones as well. But the first question, you really need to be asking yourself is this person having something that requires them to go to the hospital ASAP? So if this person's having severe chest pain or having difficulty breathing while they're talking to you, or they have, blood pressure is super high, they shouldn't be calling you, right? They should be going to the hospital. So, a big part of family medicine is really just figuring out what's the really emergent, scary stuff, and then what can you sort of manage to do, without having to send someone to the hospital. So, OPQRST is basically the onset. So like, when did it start? What makes it provokes is what makes it worse. What makes it better is what makes palliation. Quality, what is the pain sort of, is it a dull pain? Is it a sharp pain? Does the pain go anywhere? Does the pain happen worse at a particular time? How bad is it? And then you want to ask, again, this is not an exhaustive list, but, as people mentioned, this like shortness of breath, fever, lightheadedness, are they coughing up blood? Do they have evidence of a blood clot in their leg, which would then would make you think about at least whether they're having a pulmonary embolism or like a clot that traveled from their leg into their chest. The palpitations, diaphoresis just means are they sweaty, nausea, that kind of stuff. Review the family history, the medical history, see if there's any changes in the medications. These days, because, like I said, we're doing things by phone visits. The question is, I will often ask people about their blood pressure at home. Whereas, if I was originally seeing people, I wouldn't ask that. I wouldn't really ask about their blood pressure necessarily. I would just be able to check it in the office. And stress. So here's a little bit about Mr. Sunshine's history. So good thing is you find out that he's not currently having chest pain. So that's the most important thing. And he said it's been going on for about 2 months. It's very common. You think that people are, when they have an issue, they come to talk to you about right away. Some people, the second something happens, they're in your office talking to you about it. And some people, it's been like 4, 6, 8, 12 months and they're, they haven't even brought it up to you. So it gets worse after he eats. It's worse after he lies down. It goes away just on its own. He doesn't really know what makes it kind of go away. It's sort of a dull aching pain. Sometimes it gets sharp. A lot of my patients don't describe things very well, but this is also any patient. I feel like they have a lot of difficulty sort of describing things. It sort of just feels like it's in the entire chest. It's at times it gets really bad, like 8 on 10. And he sort of tells you that once he went to the emergency department and all the tests they did was normal. You don't know what that means, but let's just say that's the case. And, it's worse at night. He doesn't have really any other shortness of breath. He has a little bit of nausea, but we'll just say that he doesn't really have any associated symptoms. This is his medical history. So this is the same as the last time. So he had high blood pressure or diabetes, chronic kidney disease. He takes 1 blood pressure medication. He's a smoker. He has alcohol, maybe 1 to 2 times a night, 1 to 2 beers a night. He's got some family history of high blood pressure, but no one has any heart attack or stroke or anything like that. He does have a stressful job. He does physical labor. He started to exercise a lot more. So he does exercise 3 times per week, and, this chest pain doesn't seem to stop him from doing that. And that's really important because, you worry about, and someone mentioned exertional chest pain is a really strong indicator of something cardiac or heart related. It just means that as you are putting more demand on your heart, it's just not able to keep up with that demand. And as a result of that, the heart is probably could have, I should say, a blockage that's preventing adequate blood flow. And you want to catch people before they actually get to that point where they have a heart attack. So we'll see that he hasn't injured himself. He hasn't really tried any medications. He has no changes in his medications. And in particular, he hasn't taken any anti-inflammatories or NSAIDs. And that's actually important because, as I mentioned, peptic ulcer disease or like a ulcer in the stomach can be caused by bacteria called H. pylori, but another thing that it can be caused by is anti-inflammatory. So I have had patients who've been taking, let's say, Advil on a regular basis or ibuprofen or something of the equivalent, and have turned out to have just one day end up having cough up a good amount of blood, end up in the hospital, and they have a big ulcer in their stomach. So even stuff that we have over the counter is not without some risks. So his blood pressure at home is pretty good. It's 120 on 75. Sugars are okay. So nothing really otherwise sort of concerning. People have sort of talked about heartburn reflux. Yes, sounds pretty. I kind of agree with that. So the question is, what are you worried about? What do you want to do next? And then, this is kind of an interesting question for me as well, too, which is, does it need to be seen right away? So I'll give you a little bit of perspective. I come into the clinic maybe once a week just because there's 8 doctors. And so I have to be a little bit selective of who I bring into the clinic. So you have to sort of, figure out, is this someone that, needs to be seen right away? Can he be seen by another doctor? If I could bring someone in to see one of the other doctors, if I really have to, can I, have him booked another day? If I'm sort of convinced, and it sort of sounds like from the history, it's very much after food, the other thing, we didn't really ask, but, would be very specific. You can be very specific. Like most times heartburn is really worse after spicy food, acidic food, even beer, coffee, gets worse especially if you have a big meal or if you lie down after a meal. So he's also a smoker. So, didn't go into it, kind of wanted to leave it a little bit vague, but those are some of the questions that once you can figure out that there's no really other concerning things, like there's no shortness of breath, there's no fever, there's no palpitations, there's not that much that's super suggestive of heart related, anything cardiac. He exercises regularly. That doesn't seem to be a problem. It's been a long-standing problem. It's been at least 2 months. It hasn't necessarily gotten worse. There's some things that make you a little bit more reassured. And I have to say that a lot of these things come just with clinical practice in terms of how comfortable you feel about having someone come in right away versus, when I first started, you're always a little bit more anxious about missing things. When you get a little bit further into practice, you kind of get comfortable with knowing what's worrisome and what is not. So I definitely don't think he needs to come back immediately, like emergently. He definitely needs to get tests done. And the good thing is you can always tell people that, look, if you suddenly get worse, you go to the hospital. If something in between happens and before I do see you, just call me and we'll figure it out. It probably would be important to rule out a cardiac cause regardless. And it's because a lot of times diabetic patients do present kind of in a different way than the usual patient in terms of heart disease and even angina. So it's not, I definitely don't think it would be unreasonable. So, I do sometimes mention this, that, the care that we have here in Canada is probably a little bit different than what you have in the States. From what I understand, I've never practiced in the States, but I think there is a little bit more excessive, over investigations. I still think that we probably over investigate here as well too, but because everything is sort of publicly funded, as a doctor, I have to sort of be a little bit cognizant, is that if I'm ordering a test, does it have value? And the second thing that's also important, not just from a monetary perspective, but what people don't understand is sometimes the more tests that you order, sometimes you actually go down this rabbit hole. So I'll give you an example. You'll do a chest x-ray and they're like, oh, there's a little shadow there. Okay, but what does that really mean? So they'll say, well, you know what, just repeat the x-ray. In the meantime, you have to tell this patient, and the patient gets anxious. Then, you have to be like, well, it doesn't look like it's very concerning, but depends on the patient how well they take that information. And so then you do a repeat x-ray, and the x-ray is like, yeah, it's stable. It's not anything to worry about, but maybe repeat it in a year. So now you're going around chasing test results. So yes, there is sort of a balance between investigating something that you think needs to be investigated and sometimes over investigating and going down a rabbit hole. And I've definitely ordered tests, which I think was pretty reasonable, and then led down a place where I've made someone a little bit more anxious than I think I wanted to, where I think the actual cause of what their issue was maybe not as complicated. So a stress test is something where there are different forms of stress tests. So, the easiest one for him would probably be do an exercise stress test, would be to put him on a treadmill, and you get your heart rate up, and he's basically looking to see if your body or your heart in particular is able to keep up with the demand that is placed on the body. Here, I don't know how it works there, but we now have a system where I'm able to at least track down all the blood tests that were done elsewhere. But if someone had a chest x-ray, any heart test, ultrasound, anything like that, I may not have that result in my chart. Sometimes the hospital will ask who the person's family doctor is, so it will come directly in my chart. Sometimes it doesn't, in which case I then have to track it down. So we'll assume that I don't have these results, so I don't really know what happened, which is a very common case. So I'm trying to make it as realistic. This is really what happens. So we talked about the fact that we think it might be like a GI means gastrointestinal, so as a GI cause. So, what would probably be a good suggestion would be to trial this person on, so it depends on how bad the symptoms are. So you could try them on something minimally that you could get over the counter, like Tums or some sort of antacid. You can, I think we often forget to talk to people about lifestyle changes, which is, reducing alcohol, the smoking, reducing spicy food, acidic food, smaller meals, and not lying down after meals. It just, most people aren't really that fast at changing. And you'd be surprised when you tell people they have heartburn, or you think based on their history, a lot of them will be like, no, but I have chest pain. And you're like, yes, I know you have chest pain, but I'm pretty sure your chest pain is caused by this. And so unless they don't feel really typical heartburn, where they feel a burning sensation, they sometimes don't realize that's what it is. So it's interesting. So I have had a lot of cases that have been very similar, where I've had people who had gone to the hospital numerous times because of chest pain, and they do the same workup, which means they do probably a chest x-ray, some blood tests, and they do an EKG, everything comes back normal, and they're sent home. And so I've had a lot of people where, they end up having H. pylori or the bacteria in their stomach as the cause of their symptoms. So though the recommendations are often to, trial someone on what they call a proton pump inhibitor, it's a little bit of a stronger medication than just an antacid. It blocks the excessive acid formation in the stomach. I find that H. pylori, especially in my demographic, is sort of under investigated or looked at. And so I often, will order it at the same time. I think generally most people will treat people as heartburn, and if it doesn't get better, we'll then do the blood work. But I've based on my own experience, I've just seen it enough times. So Yeah, I'm just reading back the commentary. So yeah, people are talking about his trigger. Yeah. Yeah, Zantac Tums. Yep, these are all really good answers. So and just to sort of backtrack, and I don't really know if people know this, but I can just do a 10-second explanation. So what heartburn is, so you imagine your stomach basically produces acid, but it has a lining that protects itself from the acid. So you need the acid to break down food. What happens is you have your stomach, which is then attached to your esophagus, which is the tube where food goes into. And what happens is that tube doesn't have the protection against the excessive acid. So you have a valve, and what happens is sometimes the acid goes up from the stomach into the esophagus. And because the esophagus doesn't have that protection, it burns. Just like if you were to get acid on your hand, that would burn. And so that's why people feel that sort of like burning sensation. So I'm going to talk a little bit about some of this other stuff in a second. So, you decide to like touch base with Mr. Sunshine in a bit. You say, listen, I'm going to try to get the results from the hospital. And I'm going to, we'll book you a stress test. It's maybe down the road. It won't be done right away. So that's okay. And you're not really super worried about it anyways. And you say, I'm going to like get this, give you a trial of this medication. And so he touches base with you in a couple of weeks, and he says that he tried the medication, and this is the update. So you look at the blood test from the hospital. The EKG is all normal, chest X-ray is normal. And if this was done relatively recently, it's probably not a need to repeat it unless he sort of describes a change in that 2-week period. He tells you that he's gotten better since starting the medication, and he started to make some changes, but he started to feel bad again 2 days ago, sorry. And you do he does the blood test that you advised him to do, and that shows that he's positive for H. pylori. So this is actually, like I said, very common. Technically, if you look at the guidelines for treatment of reflux, they will usually say that you may need to have a proton pump inhibitor for 4 to 8 weeks. So again, it's not unreasonable to do like a full treatment course of that. I can just tell you that, doing like that's a month to 2 months of having someone on this medication. And if they're doing it regularly for that time, and they still have not feeling much better, and then you do the blood test, I feel like it's kind of really far down and someone's been suffering for a lot longer. So I feel like I ordered a little bit more than I think some people might. But like I said, I have a lot of people that end up having H. pylori. So what H. pylori actually is a bacteria in the stomach, and it is usually people get it in childhood in sort of like developing countries, people who are in sort of more crowded conditions, although you'll see people who have it in otherwise. It sort of stays dormant, and sometimes it can sort of get activated. And in its, as a long-term issue, it can create stomach ulcers and even in some cases stomach cancer. I haven't had anyone who's developed stomach cancer, but yes, I've seen people who've had stomach ulcers as a result of it. The interesting thing about it is if you do a blood test for it, it only tells you if you've been exposed to it, which means that at some point in your life you're exposed to it. Could be that you were exposed to it recently, maybe like 10 years ago, and the blood test may stay positive indefinitely. So it's only good as an initial test if someone's never been treated for H. pylori. What happens is that if someone's been treated and then they have recurrent symptoms, you have to do a different test to sort of figure out whether or not they still have that bacteria present. The treatment is kind of not really fun. It's a bunch of antibiotics and a medication for the stomach for 2 weeks, but then it usually eradicates it. Sometimes people need to continue the stomach protecting medication for a little bit longer. But it's incredible how many times I've seen people who've had recurrent visits to the emergency department for chest pain, and they end up having H. pylori. So that's why I sort of thought I would put this example in. Someone's asking me a really good question about why I chose to work in a low socioeconomic area and do cosmetic practice. Yeah, they're two very different practices of what I do. And the reality is that, I didn't really I had actually no intention to work in a low socioeconomic area. I happened to go there when I graduated. I got a job there for 2 months, and it was supposed to be just like a temporary job while I got another job. And then I ended up really liking this practice. You teach people about really simple things, and they just need a lot of education, and I found that it was really rewarding for me. And my cosmetic journey was a little bit different too. I just really enjoyed doing stuff that was very artistic and with my hands. And so yes, it's very different than what I do, and they're nowhere at all related. But the cosmetic day is usually like a little bit of like an artistic and a very free day, so a little bit different than what I do here. I'm happy at the end if you guys have any other questions to answer about any part of my journey, or just in terms of anything from medical school onwards. So you talk to Mr. Sunshine, and let's say like a couple of weeks or months later, and he goes ahead and does the treatment for H. pylori, and he's now doing a lot better. And just for completion's sake, we'll just say the stress test was negative. It wouldn't be wrong to say that after you treated him for H. pylori, if he got better, to like not have to do the stress test. Yeah, but again, sometimes you will find diabetics present a bit differently, and just because he's diabetic, high blood pressure, and also has kidney disease, I think it's pretty reasonable to go ahead and do that. So a couple sort of things to think about is, how would you treat this person differently if they were 25 years old? Would it make a difference or not? And based on this, if you think about it, we never really examined the patient. We talked to him on the phone, and it just happened that the blood test was positive, and we never really brought him in. So what do we think about whether or not the physical exam, like, would it have changed anything? Like, should we have brought him in? And I left it on purpose just to sort of have an interesting conversation, which is, with COVID, it sort of like changed our style of practice. And how much does a physical exam, is it helpful, not helpful? And should we put someone at risk to get them to come in to be assessed? I don't know, interesting to hear what you guys think. And in the meantime, I see some people asking me about starting my own practice. So I don't actually own the practice, but at the clinic I work at, there was a doctor who was taking care of a population of patients, and they needed someone to sort of take care of those patients for the summertime. And then she ended up moving permanently to like across the country. And I happened to be the last person who was there, and I knew half of those patients. So it was a pretty easy transition. Yeah, so someone said about what should a physical exam should always be recommended. Yeah, you know what? I find it's a very interesting conversation, because in some ways, like, I still think that the physical exam does provide value, even if it's like a negative, just to reassure yourself, just because sometimes you do find things that you wouldn't find. But it's been a bit of a struggle, and I know that might be different down there. It's the fact that, you are limited in who you bring in. And so the question is, does this person need to be seen and to be assessed in person? I definitely, if nothing would have come up, I think it would have been really important to have this person checked out. Again, if he didn't have, he has a blood pressure machine at home, and that's why he was able to give us our, give some readings. But if he didn't have a blood pressure machine at home, I would definitely bring him in. I also have a lot of patients who don't always describe things well. So this is, I'm assuming this person described this history really well. And, we get, when they teach you in medical school, it's like they give you these like perfect examples where, everyone gives you the, like, all this information. The reality is that people aren't always really good historians. So I think that sometimes I bring people in because I'm just not sure that I understand their history over the telephone. So, and someone's asking me about telemedicine. It definitely interesting in the sense I enjoy part of it, in the fact that I feel like I can do a lot while still being at home and keeping everyone safe. But there is still something about being face to face with someone and interacting with them that way. So it's I don't know, it's a little bit of it's a little bit of love hate with both options. I feel like when you're in person, I think people are just end up a lot chatty about like how's life, what's going on, which the people do on the phone too, but I feel like you get more of that in person. Yeah, someone's saying instead of doing physical exam, you could ask more questions and try to check certain things themselves. Yeah, so that's what's ended up happening, which is, you know, for our diabetics, normally we have people come in, they get their weight, their height, their waist circumference check, their blood pressure check, and and because of the pandemic, we were told to sort of reduce the inpatient encounters. And so yes, I really would ask the patient if they have a blood pressure machine or if they have a scale at home to provide me with this information. So it's interesting. I think there's still a good chunk that you are able to do quite effectively, even remotely. Like I said, I definitely brought patients in where I just didn't know what was going on, or they didn't have a blood pressure and I hadn't seen them for a while, and I just don't know. A blood pressure, especially one of those things where you just never know until you actually measure it. I'm going to move on, but if this patient was 25 years old, I think I wouldn't order the stress test. That would be the main difference. But otherwise probably do something similar. So case 2 is kind of interesting because this actually is really based, I've changed a couple of the facts, but it's based on my patient and a little bit of a very, very unique case of presentation of chest pain. So we'll pretend this is Mrs. Sunshine. So she's Mr. Sunshine's wife. She's 42 years old, and she basically went to the Caribbean for a tummy tuck procedure during COVID. And this actually happened to my patient. I told her not to go, but she wanted to go. And she basically calls you because she has some chest pain and she thinks she has an infection. And this is actually what she says. She says to you, well, I'm hoping, doctor, you can call me a prescription to the pharmacy because right now I'm in quarantine and I'm pretty sure this is just an infection and it's going to go away if I get some antibiotics. What do you guys think? What would you do? In the meantime, I'll answer a different question. People are a lot more scared and anxious to tell all their medical history. Yeah, building rapport is such an important thing. And I think that's one of the best things that you have as a family doctor is you really build a rapport. When people go to the hospital, I feel like a lot of times they feel rushed, which makes sense. Second of all, I don't feel like they're able to sort of open up in the same way that they're able to open up with you. And yes, there are certain really personal things that I think are much easier to do in person. There are some really people have gone through some really hard things in their life, and I think it's a little bit easier to talk to someone about it in person rather than over the phone, or even giving bad news. I think is a little bit easier when you're face to face with someone. So someone's like, no, do not prescribe, get signs and symptoms. She needs to go to the hospital, ask more questions. Yeah, these are all you guys are really good. Yeah. This is, you guys are saying like, don't give a prescription. Yeah. And so let's find out a little bit about what's sort of going on. So she's basically had a bit of chest pain, but she doesn't feel like it's really that bad. She got her tummy tuck procedure like a week ago. Then she literally just got off the plane. And then, she decided she sort of felt this chest pain. She doesn't have any swelling in her legs, which would, indicate perhaps a blood clot in her legs. She says she feels a little bit warm or feverish, but she doesn't really know. So she doesn't even know if she has a fever. She's like, yeah, I kind of feel short of breath. But it's fine. It's there. She said the chest pain's been pretty constant. It's sort of like a stabbing pain. Otherwise, she's pretty healthy. She's got anxiety and she's got a hiatus hernia. So just like a little hernia in her stomach. But that's really just about it. So other people are asking about the procedures and stuff. Someone asked about privacy concerns. Definitely some privacy concerns are for sure there. Even we do have like a video chat, like secure network, but the problem is a good chunk of my patients don't know how to use a computer or don't have a computer. So hence why we do a lot of phone calls, which is, I think, a big limitation. Yeah, someone is basically, what else has she done or taken place, that kind of stuff. So, you know, I just told her to go to the hospital. I also, I think, when someone talked about the rapport, I also know her really well. And, she, even prior to her going, she tells me a lot of things, but didn't tell me she was taking 14 Tums a day. So, I kind of know that she sort of underplays a little bit about what's going on. And so, I think that also sometimes is really helpful when you know your patient, and it doesn't sound right. She had a procedure, she has chest pain. There's no way you can figure out what's going on without at least seeing her. And, she may need to have some more emergent tests done, which you're not going to be able to do. If she comes to see you in the clinic, let's say you book her for the next week and you're like, okay, yeah, come to see me. That's going to be a whole lot of time that's wasted. And you don't really know what's really going on. And if she felt feverish, does she really have a fever? The history is too vague, and you have no idea what's going on based on this. It just doesn't sound right. So if your gut tells you it's wrong and that she probably needs to go to the hospital, you're probably right. So this is actually what happened. I got a report from the hospital the next day. So she went to the hospital. Turns out she has a blood clot in both of her lungs. And she also had a really bad, severe infection. So she was right about the infection from her surgery. But basically, she had to go back to the operating room to drain a lot of the sort of like excessive, she had, like, they're called seromas, like excessive like fluid buildup with infection as well. And she needed to have some grafts. So basically, areas where the skin was damaged, to take like healed or non-damaged skin and have a graft put in. So yeah, someone said, yeah, Tums. Yes, this patient, but prior to her surgery was taking 14 Tums a day. Tums, yeah. I don't know why she wouldn't tell me that, but tell me a whole bunch of other details. People are, you realize that, like, people are really interesting. They'll tell you a whole bunch of random facts that are irrelevant to their health, but then miss very important facts about their life. Yeah, so someone was like, recent surgery and flight equals PE. Yeah, I mean, very, very, like, that's one of the things that you have to be able to figure out, which is, like I said, what are the scary things that need to be treated ASAP and what really doesn't. So I kind of wanted to give a contrast from the first case, which is, that, though he had a stronger like history that was more concerning, when you listen to like, sorry, like his medical history was more concerning just on terms of his medical conditions, but his story wasn't really as convincing of something really bad happening. Her story didn't sound right. So I think if you go by what the story is, I think that gives you a lot of confirmation. So yeah, and I actually I talked to her while she's in the hospital. She's really funny. She's like, Doc, I think it's kind of bad. I was like, yes, it is really bad. so anyways, the learning lesson that I just wanted to sort of go over is that, having to determine what's an emergency and what can be sort of monitored. And a lot of times patients will convince you of something like, yeah, I don't really think I need to go to the hospital. And at the end of the day, you can't, I think I mentioned this in my first talk, you can't convince anyone to do anything. Your job is not to convince per se, is to provide people with the education so that they can make an informed decision. And you strongly suggest them to go do something, and you just document it. Again, the rapport helps. I have a good relationship with this patient. So she was able to, though she was really reluctant to, did listen to me. And I'm really glad that she did go. Like I said, she probably would have ended up in the hospital, maybe later, maybe in worse condition. It's hard to say. So let's bring Mr. Sunshine back. So he's got his got treated for his H. pylori, and now he's come back to your practice. He's come back to sort of talk to you 6 months later, and now he has chest pain again. So which happens, like, just because you have chest pain doesn't mean you can't have chest pain later. So what are we going to do now? Yeah, there was a really amazing episode. Yeah, it would make an amazing episode of House. Yeah, it was a really interesting story. I mean, I told you the backstory to it. She actually went to the Dominican earlier, and then they told her that she had a lump in her chest, and she was told to come back. And when she came back, she called me, I was like, I don't know what this is, and I got her investigated, and it turns out she has that hernia that I talked about, which is not anything of concern in the sense that it's not going to prevent her to have surgery. So she already went there before, almost got surgery, was sent back, and then still decided to go back after I told her that she shouldn't. So it's an example of what I'm saying, that, you can have a good rapport with someone. And, we had a really honest, open conversation. And she said, I know you're disappointed in me wanting to go, but I need to go because this is when I have time off. Again, you can't control what people want to do. It's their life, their body, their money, their time kind of thing. It just sucks that for us as Canadians, when she comes back, all of her care is now taken care of all of us taxpayers. Yeah. So that's where these types of things are very, very annoying to see, because this probably could have been all avoided, and it's definitely something that was not like a required procedure. So, we're talking to him about, what would you do in terms of like, how is this chest pain different? Has he been taking any medications? Has anything changed? All good stuff. Yeah. It's also a really good question about how do you keep yourself motivated? I think in the beginning it was really hard when patients didn't listen to your advice, even though you felt like you knew better. But it happens in a lot. It's very interesting. Some people will come back and they'll eventually listen to your advice. Some people won't, but it's interesting. Sometimes even a year or two later, with time, they kind of realize that you were probably on the right track, and they come and ask you back for help. So I've had some redemption. And I don't mean it in a redemption in the sense I want to be happy that I convinced someone. It's just, I want to have my patients in as best medical health as possible. And so, like if I can see a problem that I can solve, and it's really frustrating when I can't solve the problem because, patients don't want to do it. Okay, so moving on. So he basically says his chest pain comes and goes. He's not really having any pain right now. It's not related to exertion. He still exercises. There's no shortness of breath, no lightheadedness, sort of a dull aching pain, kind of similar to what it was before, but it's sort of worse when he like moves around and like, if he like sort of like touches the chest, like in general. And nothing else has really changed. No medications, nothing else. So what else? Yeah, someone talked about breath test for H. pylori, doing a blood test, showing chest x-ray. Yeah. How often does he get the chest, do an EKG, like a CT chest? These are all really good questions. So you said, I thought do a little bit of a different approach. Let's bring him in. Let's have him assessed. So you check his blood pressure, pulse, everything's okay. Listen to his chest, everything is fine. One thing we didn't talk about, and I didn't put in my differential, but is actually one of the things that you miss if you don't. To be fair, you can ask someone about this, but shingles, which is a reactivation of the chickenpox, will present as a rash and can actually be on the chest. So some people with chest pain, interestingly, so the initial part before the rash comes out, you can just present with sort of like a burning sensation. And so you could technically present with chest pain without a rash. So something we didn't really talk about, but not super, super common, but yeah, shingles is common enough for it to happen. So, when you examine him, the pain sort of gets worse when he raises his shoulder on the right side of his chest, and you can really like palpate it. So like you can just feel it sort of like it's tender to the touch. And as he raises his shoulder, that it seems to really make that pain sort of start. So does that change what you guys think? And people are talking about doing like blood work and x-ray. So to be fair, it's interesting because, we also don't know. As a diabetic, he needs to get blood tests done, or he should get blood tests done every 3 months as it is. So I just made a little bit of the assumption that we'll just say that he's had his regular diabetic blood work and it's been normal. Another interesting thing to talk about as I wait for you guys' answer is, when you think about it, like what blood tests are really super important in chest pain? When you really think about it, the main one that, is sort of, you think about is related to like an MI or a heart attack. And, those are like troponins and stuff, which don't get done in an outpatient setting. So that's really only done in the hospital. So really, if you thought someone's having a heart attack, that's why you send them to the hospital, because they have to usually be repeated again. If they're, to rule out an MI, if that's what you're thinking. But like, for example, there's not really that many other things on that differential that you would kind of just see on a blood test per se. So we often order blood tests. You usually order like a sort of like a basic blood, like a blood panel, but it in all honesty probably doesn't make so much of a difference there. So I'm talking about like bleeding, exercise injury, pulmonary effusion, yeah, in recent injuries, that kind of stuff, shortness of breath. So I think he didn't have shortness of breath, muscle pulled, yeah. Yeah, so someone's asking me about not people doing what I want, yeah. Yeah, I've definitely dug deeper a lot into certain people that that just didn't want to didn't want to go ahead and do certain things. Some people have really fixed values on what they think. Some people who see a doctor, but they don't really believe in Western medicine, which is interesting. So you have people who want to check their cholesterol, but then be like, oh yeah, it's high. I know it's high. I've had high cholesterol since I was 30 and I'm now 60. But I just want to know what it is, but I'm not going to change anything on what I'm going to do. I just know that if I'll just start eating better, it'll be fine. And you talk to them about the risk, what can happen, this and that, and they say, yeah, what, I have lots of friends who have this, and I'm just some people are extremely shut off, like they just will not talk to you about it. And if you approach it from a different way, I give them, I've done scary stuff. I've done like okay, it's your choice. I'll say I'm not your mother. I've applied a lot of different ways to sort of, figure out what's the underlying issue. Sometimes you find out, what's the underlying reason. And like I said, sometimes people are just scared to know the answer. Like they don't want to know, like they don't want to do a mammogram. They don't want to know if they get breast cancer. And which is interesting because you'd almost feel like, well, but if you know now, you could do something about it. Whereas if you find out later, you won't be able to do. But that theory doesn't really work or resonate with them. I have, like I said, opened up to certain people to go do things. I'll give you an example. Today, I have a diabetic patient who she's been really bad with her, really nice person, but she just doesn't really want to be on insulin, and she should be. And now she's had issues with her eyes as a result of it. And, she's had to have surgery and all this. So I talked to her today, and I like her blood test, her sugar is super high. And I told her, like, I had this whole speech prepared in terms of how to convince her to start on insulin and go to see a specialist. And I started the speech, and then I asked her what she thought, and she's like, yeah, I was thinking I already want to go on it. So, I mean, I've been trying for a really long time to get her to that point. And you know what? Sometimes people just need to get there on their own. And, sometimes giving people a little bit of space, and unfortunately, sometimes things happen to people and then they sort of change their mind, which is obviously not the way you want it to happen. But, people, like I said, do change their mind. So, we didn't really talk about, I sort of briefly mentioned it, but I'll just go back. So he has a physical labor job, and he does a lot of repetitive movements. And so, he probably has a muscle strain injury in the pectoralis muscle, just the muscle that's overlying the chest. And so the reason I wanted to sort of give this kind of case is the fact that, again, a lot of muscular chest pain is sort of not missed, but like people don't really think of muscular chest pain as a cause of chest pain because everyone is very focused on all the other stuff. Would be completely reasonable to check out a couple of other things as well too. Again, sometimes it's hard when if you go by what is the most obvious thing, if it quacks like a duck, it probably is a duck kind of thing. Whereas, if the pain is really specifically related to movement, you can palpate the pain right there. He has, especially if he tells you that, he's been doing the same job over and over again, which is a lot of my patients. It's not really surprising to me that he does have sort of like muscular chest pain. And so, yes, you can go ahead, and if you wouldn't be, I don't think it'd be incorrect to investigate it further and go back and do the chest x-ray, but he doesn't really have any of the other symptoms that makes you concerned about anything else. So yes, we talked about the fact that, diabetics can present in different ways, but it doesn't sound like angina or a heart attack or anything. And he just had a stress test not so long ago. So, my level of suspicion for that is not really so as high. Yeah. So, one of the things that you can do is just tell them to sort of not do as much of that repetitive movement, which is really hard for my patients because that is their job. And, I often will talk to patients, I think he's 50 if I'm right. I will sometimes talk to patients about, whether, if they do a really physical labor job, like, would it be something that they would be able to do ongoing? Because sometimes that needs to be adjusted. So, for a lot of these muscular pains, we will often prescribe an anti-inflammatory, but he's diabetic, he has kidney disease, and he has this previous issue with H. pylori. Sorry. And so that would probably not be a good choice. So I would not give him an anti-inflammatory for all of those reasons. So I would probably, especially if he hasn't tried anything, probably start him on like just basic Tylenol, exercise Tylenol, or acetaminophen. There are other medications that you could take that if, this doesn't seem to get better, to sort of put him on a little bit of a stronger medication. But you can probably tell him to take it on a regular basis. It would just tell him it is safe for him to take it on a regular basis if required. And I would much rather him be on something like Tylenol than something else a little bit stronger. So let's go back to Mrs. Sunshine. So she's come back to you, and it's 11 months later, and she's no longer on her blood thinner. So that's good. She's healed, and now she tells you that she has chest pain as well too. But actually, when she talks to you about it, she's like, yeah, it's actually been on for like 2 years, but she just keeps on forgetting to talk to you about it. Also very common where you'll have someone talk to you about chest pain that's been there for years, and you don't know why they haven't talked to you about it yet. Oh, someone's asking about a cortisone shot. So yes, you could do a cortisone shot if it's a cortisone shot is a little bit more helpful in the actual joint. So if it was like actually within the shoulder, like you could do a shoulder joint injection. Most injuries will take, or sort of strains will take about like 4 to 8 weeks to sort of improve. So the other thing I went really quickly through it, but physiotherapy, actually sending him to go to do a round of therapy where they actually do exercises to help stretch out. It's a lot of repetitive movement, but also, the type of like, generally our postures aren't very good as well too. So there's probably a lot of other things that you could do for that. Yeah. Someone's talking about how you have to let people kind of accept them to go on their own route. It's hard. Yeah. It's like, I think it was way worse for me when I first started because I felt like I could help people, but then couldn't, kind of thing. So let's talk about what to do for Mrs. Sunshine. So this pain's been there for a really long time. So, I mean, I get, are we worried, not worried? Is it related to, this other thing that she's had? Probably not. It's been there for a long time, even before she had surgery. So let's talk about her chest pain. So her chest pain lasts about 10 minutes. And, it happened about 2 years ago. When it first happened, she freaked out, ended up in the hospital. They did the normal investigations to the chest x-ray. They did the EKG, the blood test, everything was fine. That first time when she's like, oh, it was really bad. I couldn't breathe. I felt lightheaded. I had palpitations. I was sweaty. But then when she went to the hospital, they're like, yep, all your investigations are fine. You can go back home. So, and then, follow up with your family doctor. Also a very common statement that gets made. So what should we do next? So, it's interesting because in some ways when you look at those symptoms, like they sound concerning, but like, are we concerned about this or not? Or yeah, the questions could be an anxiety attack. Someone said check blood pressure. Yep, good thing to do. Yep, stress and anxiety, all really good things. Yeah, anxiety attack. Yeah. So, we go back and we look at what was done. So, 2 years ago, she had all these tests done. So it's not unreasonable to consider repeating some of this stuff again. You could bring her in if you haven't. And, she's really anxious because the reason why she called you. So, you think to yourself, like, okay, well, this person had this problem like 2 years ago. Like, why are they calling me now? So again, when someone asked about, like, digging a little bit deeper into it, the question is, so like, oh, well, what made you like, what made you call me now if you've had this pain for this long? And so you find out a little bit, she's really anxious because she had an episode really similar to the first one she had last week. So that's why she's worried, because suddenly, like, she had a really bad one in the beginning and then she had kind of sort of recurrent stuff. So an interesting thing that, we talk about is, anxiety is sort of, there is like DSM, which is like the sort of like the Bible in terms of like how to diagnose anxiety. But in some ways, if you actually look at the DSM, it'll say it is not caused by any other medical condition. So in the sense that you have to almost rule out everything else before you can technically say that someone has anxiety. And so this is kind of like an interesting topic, which is that, sometimes if someone has anxiety, sometimes, and I'm sure I've done this too, where you sort of think to yourself, well, this is an anxious person, like this sounds like anxiety, so like I'm going to treat it like anxiety. And so sometimes you can fall into this little narrow view as well too. So the whole point of this example is to sort of say that, you have to, every time someone presents to you with a problem, it's important to keep an open mind, because you just never know sort of like what it could be. And so even though you think that anxiety might be the cause, it sort of still sounds like to be. So we'll say that, like her investigations are normal, her vitals are all normal. Let's say everything else is normal, right? And when let's say you bring her back in to talk to you again about what's happening. And she says, you know what, like I really haven't been sleeping well, because that the anniversary of my surgery is coming and that's giving me anxiety. So, when someone asked about like probing a little bit more, it is interesting to sort of to see that actually can be very helpful. And when you go somewhat a little bit superficial with people, and if you're looking at everything from just a very medical perspective, like, okay, like, is it this, like I'm going to do my blood test, I'm going to do my x-ray, and I'm going to do my EKG, and all of them are normal, and you just say, yeah, all these things are normal, so like, you don't have anything that's bad, so like, like keep an eye on it. And sometimes we forget to dig a little bit deeper, and when you dig a little bit deeper, you sometimes find some answers. So, and some of the stuff is, again, a little bit on the more social perspective, which is very fascinating for me as a family doctor. This is a lot of what my job is kind of digging deep into this sort of, other aspect of patients. And so we often forget to review the medical history. So, sorry, to finish that off. So, the example was just to sort of say that she was probably having a panic attack. So you refer her for counseling and you follow up with her. So that's what I wanted to go with. I want to have one last case. I know I'm kind of running out of time, but it's also a very interesting case, so I thought I would bring it. So this is, a young patient. So we'll say this is, Mr. and Mrs. Sunshine's daughter, and she's been in your practice for a while, but like you met her once only 2 years ago. She's otherwise healthy. She has new chest pain that is getting worse. So what do you want to know? And just for a little bit of time's sake, I'll try to go a little bit faster, but I mean, you guys can still go ahead and, type in things, and I'll kind of watch that as well. So she's born in Canada. She's otherwise healthy. Her chest pain's about a 6 on 10. It's been getting worse though. And she feels nauseated, short of breath. She's very tired, doesn't have a lot of energy. So she's in school right now, and she's just really having a hard time struggling. So what do we think about this? And this actually also happened to me. This is a real case. And it was interesting because presented a little bit differently. This person didn't tell me about their chest pain. They just told me that they were tired, not feeling well, and like school's been really stressful. And that was sort of the way that it was sort of, explained to me. And then at the end, like I was just about to leave the room, and this patient was like, oh, and I have chest pain. And it's your worst nightmare when you have someone who tells you that they have chest pain as they're about to leave, and you've already talked to them for a good amount of time. So I was like, oh, okay, sure. Tell me about this chest pain. And this is sort of like a little bit of that history. Yeah, someone's asking about being like I call myself a mini psychiatrist. In Canada, it's a little bit difficult to get like access to psychiatry, and so a lot of times I will do a lot of the initial counseling. We have access to social workers in our office, which is kind of nice, which not every place does, and they're free, and so. Yeah, it is sometimes when I basically have patients who are on multiple medications and I still can't figure out what to do, and there's maybe a lot of complicated history, trauma, abuse, things that are like much deeper than what I have maybe the time and effort to be able to spend the time on is usually when I refer. Yeah, someone's asking about like physical work and stress and all this kind of stuff. Yeah. Good question. Low iron. Yeah, actually, it's actually that's a really good suggestion, because you not that common, but sometimes people are just really short of breath and they have low iron, and so that's a very good suggestion. So like she doesn't look like super unwell. Her blood pressure and stuff is fine. Like her chest, all that stuff is okay. She's a little bit tired, but there's not really anything else that you sort of like see when you examine her. So this is sort of based on a real case. This happened prior to the pandemic. So I'll just assume I was actually able to talk to her and then like see her right away. And so what do you do? And again, this person's sort of like, yeah, I have this chest pain, sort of, yeah, I've been tired. Like, are you worried? Not worried? Like, what do you want to do? Yeah, enough sustenance and stuff. Yeah, good question. Good comment. So, I mean, this person definitely needs to get some investigations done. I would probably still do a chest x-ray, you do an EKG, and then blood work. And probably like in this case, when someone talked about like iron and all that kind of stuff, like, yeah, iron and thyroid for people for fatigue, for like B12, like that kind of stuff, I probably would, just because of how this person is sort of like not feeling well. And so this is actually what happened. So 2 days after I saw this patient, I got an urgent call from the radiologist at the imaging center. And they said this patient has a large mass in their chest and they need to get a CT of their chest immediately. So I, called this patient, and I found out that she felt unwell and it ended up in the hospital just the night before. And they did a CT of her chest at that time, and they think that she probably has lymphoma. So this was probably within the first couple years of my my practice. And this case kind of threw me off a little bit, because it was a young person who was previously healthy, who didn't really have anything else. And her symptoms were a bit vague, but she's like, yes, I feel tired and I don't, I can't keep up at school, and like, so there's something in that part of that story that just didn't settle right with me, that I knew that there was something that was kind of off. Them talking about the x-ray and talking about the chest pain was a very last minute thing. So kind of shows you that it, yeah, like I said, open to anything at any age, it can happen. And so, the whole point is it's important to get a good history, consider the person as a whole, consider the social aspects, not trying to like dismiss people's complaints. And like I said, it's kind of this important balance. And this is, I think, where the art of science of medicine exists, is where you're trying to figure out the balance between investigating someone properly and then not doing too much. Because like I said, it can sometimes create more anxiety for everyone. So sort of like the end of my presentation, I think last time I gave a quote as well too. So I just feel like some of the traits that are not appreciated as much as kindness and empathy, and I feel like that both of those things go a long way. I feel like whether it is for patients or anyone else, I feel like it's something that really can make a big change in someone's life. So that's my presentation. You are more than welcome to email me or send me a message on Instagram. And the whole point of my presentation was to provide chest pain in family medicine, but in different aspects of how it presents. They're all really based on very some of them like a little bit of bizarre cases. Those are the one-offs, but kind of interesting cases that I've had over the years. And then some of the muscular stuff, the heartburn stuff, that's very, very common. So, wanted to also give you the common complaints as well too. This person actually didn't have any pain in their arms or anything. Also, to be fair, was a very weird telling you, we talked about something else, and then at the end of this conversation we talked about chest pain. So it was a bit of a I was like, okay, I guess you should go get these tests done, and I just wrote them out and sent her home kind of thing. I can tell you I did not expect that diagnosis, so definitely very interesting. You guys are very welcome. I hope this presentation was helpful. I know that's a little bit past time, but if you guys have any questions specifically about medicine or any aspect of family medicine or anything like that, you guys are I'm happy to answer them. Or if anyone doesn't feel comfortable, like I said, you can message me separately. I would say this, I was never really good at interacting during presentations, so I kind of get that as well too. You're welcome. I'm glad that you found it insightful. I tried to give this from a very different perspective, which is to sort of give a, full perspective on family medicine, just outside of the medicine perspective, which I think you learn a lot about in medical school. I think it's a lot of these soft skills that no one really teaches you, which I think are sometimes even more important than the medicine. Everyone who gets into medical school is going to be smart enough and is going to learn the proper medicine and skill set. It's the other, the soft skills that really, I think, make a doctor really special. And I think that you don't have to be the smartest person. I don't think I was the smartest person at all in my class. But I think if you have the heart and compassion, I really think you can do really well as any type of doctor. I'm glad you guys are entertained. I have to say, when it comes to presentations, I nothing worse than having someone bored in your presentation. I've been to a lot of boring presentations in my life, so I try really hard to make these as entertaining or engaging as possible. So I appreciate all of you guys, and like I said, hopefully it was helpful.
Thank you so much, Dr. Ramzan, for presenting to our web shadowers again. It was an honor to have you back. And we love how interactive you made this session and acknowledge all of our participants. Thank you.
Yeah, no problem. It's always a pleasure. And I think I really love teaching you guys. So you know what, maybe you'll see me again in the fall when you guys are back in place. So I would love to do that.
We'd love that. We'd love to have you again.
Everyone, make sure you check out her socials to learn more about her. Her Instagram is Hey Dr. Sarah.
Yeah, I can answer a couple of questions that people have before you leave. Someone's asking me about how much time do I spend doing family medicine versus cosmetics. I spend about 3 days doing family medicine, and I spend about 1 to 2 days doing cosmetics. I probably spend a lot of evenings catching up on family medicine. It's probably a little bit more than 3 days of the week, but that's sort of my division. Someone asked me about the best part about family medicine. I think it's continuity of care, getting to know your patients and feeling like, that you really get to know them. Coolest thing for me, I always wanted to be a pediatrician, but when you see kids born and then you now get to see them and they're like 6, 7 years old, and like you took care of them that whole point. You saw the mom while she was pregnant, and now you get to see them. Now she's like got 2 kids, and I just think it's such a cool thing to be in. I think everyone loves like emergency and surgery, and there's like they're very like interesting in the sense. But I feel like family medicine is like, you really form this bond with people. Right? When you work in the emergency, you don't get this bond. Like you figure out what's going on acutely, then you send people home. You don't really get to find out. So if that's I think you have to find what's your like jam. What do you really like doing? But for me, I think this really works well because I think I like to form relationships with people. And I think that's all the questions. I said, if anyone has any more, they can always just message me.
Everyone, feel free to message her. Her Instagram is at Hey Dr. Sarah. So if you have any questions, feel free to reach out. I wanted to let you all know that this weekend we're going to have our summer roundup, which means that every form for both June and July will be reopened. So if you would like more information about that, you can check out our Instagram or our website, and we have information up there. I'm about to post the link to today's form in the chat, so please fill it out within the next 30 minutes for us to receive your verification. And it's also going to be in the description of this video right now, so please fill them out. Again, thank you so much for coming. We loved having you, and this was so entertaining, and you really gave us a really good perspective about family medicine tonight.
Thank you so much. Hope you guys have a good rest of the evening.
Thank you.
As well.
Hope to see you soon.